Hello to all of you that are watching. For those of you that have watched some of our webinars before, you're probably aware that we take quite a formal approach, really, and I've had some really good people in to chat. But today, we thought we'd do things a little bit differently. And my good friend here, Moss, who will get to introduce himself in a sec, was just starting to ask me some questions about some bike fit stuff and some cycling related injuries. And we thought, do you know what? Why shouldn't we just hit record? Now we want to keep this super cash. So if anyone's got any questions, ping them in the comments box and we can get back to you at a later date because this isn't live. But hopefully this will help you to just start to problem solve some other kind of diagnoses that might exist, because there's quite a few injuries, I would say, in cyclists that get misdiagnosed. So, Moss, do you want to say hi to everyone and I guess give people a little bit of a background, because they won't have the insider information that I have. So,
thanks, Bianca. No, as you know, qualified quite a long time ago, as we both did. Spent a long time in the NHS, which was fabulous. So did all the core rotations, and then specialised in musculoskeletal physiotherapy. And then around 10 years ago or so, started work for Transport for London as a physio, which was a really great experience, all the while working in pro and semi-pro rugby part-time. And then since 2017, had a bit of a change in tack, went freelance. So I've been lucky enough to work with GB Skeleton, GB Triathlon, and Lord of the Dance, thanks to you, Bianca, which is a professional dance show. And now working in a private practice in London alongside some rugby stuff and still some elite sport.
You missed the important bit, the fact that you're actually technically living in Italy now.
Well, yeah, so also technically living in Italy, which is fabulous. The commute is not so enjoyable, but it allows me time to get some sunshine and enjoy some good food. And let's see, just enjoying the path of being a roving physio, which is great. And that's pretty much it. And also, well, the reason we're friends, apart from working together, is we both like being on the bike. I've just got back into it after a little while of a break, but really enjoy watching and trying to figure out what's happening in terms of the riders and how they're working. And having done a sports science degree, which I should have mentioned, sports science and sports rehab degree before I became a physio, really interested in what's happening in terms of that kind of environment. So that's pretty much me, I suppose.
A bit flatter in London than it is back home for you.
It is a bit flatter. Although, to be fair, any slight incline is more than enough for me. Doesn't have to be particularly steep. Hopefully that'll change. Now that I've got a 42 in the back, it should be better.
Let's hope you don't need to use that too much.
Oh God, I don't know about that. I can't remember what's on the front, but it's so small, it's great. It does allow me to turn the legs over quite quickly, I'll tell you that much.
You guys have been seeing a couple of cycling related MSK problems, haven't you, down at the clinic? Do you get many in London?
Yeah, so it's interesting since I used to work in the city of London in a gym before I became a physio, and there was always really some hardcore cyclists. So you'd always have a core group who'd have done things like L'Etape and Marmot. And would go over to Flanders and ride the Tour of Flanders route, or would do some Milan San Remo. But after the bomb attacks in 2005, so a long time ago, cycling really took off. And now London really is a cycling and a cyclist town. Lots of people commute on a daily basis and turn their commute into their training rides. So I know some guys who used to cover 60k each way on a daily basis. As part of their normal routine. So you really do start to see more and more cyclists. So currently I have two who I'm seeing, both slightly older gentlemen, but who've both been riding for quite a long time. One who has some knee pain and the other who had a little slip and has another problem going on, but he's doing really, really well. And what was interesting is that they one of the things they're finding is adjusting on the bike, especially with these problems with knee pain. And then secondly, one of them, when he swaps over to his winter bike, always finds he gets lower back pain, which is what sparked my question to you. And also following that article that you were involved in recently about back pain and cycling. So it's what kind of things to look at. Is it cycling causing the back pain or back pain while you're cycling? And how do we go about differentiating, and what should we do to tackle it? Especially as a kind of lay physios, non-expert physios when it comes to bike fitting.
Yeah, a bit of a complex one, the back pain. But I think one of the other ones that we were talking about was looking at the kind of pains that you can get around the ischial tuberosity.
Yeah, very much so. It was from a hamstring tendinopathy we were talking about, wasn't it?
It was, yeah. I mean, I guess here's a question for you, because what's the first thing that springs to mind? Let's say you had a cyclist that comes in and says, right, I've got buttock pain, it's well localized, it's here, it's around my tuberosity. What's the first thing that springs to mind?
Well, it's interesting. I don't know if even the cycling springs to mind, first of all. So first you think about the buttock pain, and I think generally in the subjective interview, you're initially thinking, oh, do they have back pain that's referring into the buttocks? That's probably my first port of call. And obviously in the subjective history, yourself, sometimes trying to get information from people can be a bit difficult. So it's trying to make sure that you really delve into their social history and what they like to do. Thankfully, the clinic that I'm in currently, we tend to get people who are very sporty, and generally they're very forthcoming about what they do because that's what they want to get back to. So that makes it a bit easier. But in terms of pain in that area, as I say, back pain, thinking the bursa, and depending what else have they done. I mean, have they got pubic-related groin pain? Have they done anything else? Because we tend not to think of cycling as something that will give pain in that area, even though obviously when you know a little bit more about it, it's perfectly obvious that it can do.
Yeah.
So that's where I tend to go first, really, and then try and narrow it down. The one problem we face, I suppose, is a lot of people don't think about bringing their bikes in to see, for us to see as well. So we don't necessarily get to see their saddles or how they wear, which is obviously something we would very often do with their shoes, or if we have a look at their feet or their arms, just to see where they're working. I think that's somewhere we miss out a little bit. I know from chatting with you, I think we probably tend not to think of it too much. I've seen you do some stuff about shoe fitting. It's not something I would really look at with cycling, but again, something that makes perfect sense when you think about it.
It's a difficult one there, isn't it, to try and fit that into your session time, especially when you're already having to prioritize what you're assessing.
Yes. Again, we're lucky here. A large percentage of our patients are non-insurance, and they pay for an hour, which means we get that extra half hour or 15 minutes, depending on where you are. It makes a huge difference in terms of what you can cover. And again, I suppose the nature of it is that because the patients are keen to return to their sport, they're willing to invest in that little bit of extra time to try and get a solution. So it also means they're open to exploring other avenues in terms of exams and what we do with them to figure out what's happening, which makes a huge difference.
Definitely. Yeah, I think with these kind of guys as well, like, you're right, you might think, right, okay, back, you might think hamstring tendinopathy, but the practicalities are, if let's say this problem is simply only present on cycling, it makes you start to think, all right, well, there might be certain things anatomically that are more likely to be a problem, because obviously, your hamstring tendon might give you some problems in sitting, etc., but it might not. But even still, it might not behave the same way as in a runner. And I guess it's interesting to hear that that's what you say, because it's what a lot of other people would say as well. Right, I'm thinking back and I'm thinking hamstring tendon. But if it's quite well localized, we would normally start to think, okay, well, actually, maybe that is quite a local pathology. And I think the thing that a lot of physios perhaps don't realize is actually that the bursa can be a really big driver for pain symptoms. It might not be in the typical population, and look at GTPS, we've moved away from the bursa there being the kind of driver behind the symptoms. But absolutely, this is a completely different kind of loading kind of mechanism really on the pelvis. And actually, if your hamstring tendinopathy has been treated clinically and it's not getting better, in fact, if anything, I would often think the bursa is often perhaps more implicated than the tendon.
I think, as you say, I think it's about the reasoning process, isn't it? I think if you consider what you've seen, what you've examined, if it's not painful on sitting, which typically a hamstring tendinopathy is, and you kind of rule out all the other causes, what other structures are left? I mean, it is possible that the nerve, if there's a branch of a nerve that shoots off there, that can get irritated, but the likelihood is it's going to be, as you say, a bursa. I think the problem we face with modern physio now is that, especially with social media, certain diagnoses have become, well, and rightly so, I suppose outmoded, outdated, whatever you want to say, for a particular problem. But what tends to happen is we throw the baby out with the bathwater and we forget that, so while a bursa isn't necessarily a problem at the hip, actually it can be at the elbow, it can be at the knee, it can be at the hip, it can be at the it can be at the shoulder, it can be in the groin. So actually, we shouldn't stop thinking about that. And again, it comes back to just trying to have a clarity when we're in a session, thinking about it in a very logical way, and not poo-pooing things just because we've half heard a conversation or half read a Twitter thread. The Irishman comes out, a Twitter thread, or X thread as it now is.
X, yeah.
Which rules out the bursa. So again, we should be thinking about any structure. We're all guilty, aren't we? I think we're all guilty of it. Same around the knee. We forget there's the Safinous nerve, there's the fat pad, there's the patellar tendon, there's the tibial tuberosity. There's lots of stuff that can cause pain in quite a small space. So we need to think about all of those things and not throw the baby out with the bathwater, and just really consider what we're looking at, really.
Yeah, definitely. And I think what I'd just urge you guys to kind of look at is, really have a good palpation around the ischial tuberosity, because a lot of the time, if the bursa is an issue, you're going to feel that sac of fluid normally. And you might need to put the individual in different positions to really kind of get into it. But, you can get, inflammation of that bursa, but you can also get a hemorrhagic bursa. And if you guys check out Dr. James Noak, who probably a lot of you know already, he's put a really good example of quite a severe hemorrhagic bursal case in a cyclist where he aspirated, quite a large volume of fluid. And actually, we can go down that rehab of, loading the hamstring, all that kind of jazz, looking at biomechanics, but sometimes it does need a medical intervention as well. And that's why that diagnosis is so key there, to make sure you, no pun intended, but, get to the bottom of what's going on, really.
You're right. I think sometimes as physios, we tend to be very determined to solve the problem, and we sometimes forget that an early referral is very useful. For instance, today I've referred someone to James with a knee problem. I think I'm going in the right path, but a second opinion would be very useful for a couple of reasons. In terms of the anatomy of this person that I'm dealing with. So I think we forget that, as you say, exactly, sometimes a medical intervention is needed, or an opinion at least, from a trusted source, or some imaging. Again, imaging is something that's been poo-pooed quite a bit, but it really has a role to play in certain environments. So you have to pick and choose. Of course, you don't want to just expose people to radiation or anything, or invasive, or not invasive procedures, but unwanted procedures or unnecessary procedures. But sometimes it can be very, very important. And there is an element of trusting the gut, isn't there? I think we sometimes, especially when we go on in our career, we sometimes don't want to trust our gutters anymore because we think, I should know this. But actually, it's really quite important if you're not happy with something to image it, especially, as you say, around that area. There can be, if you had a hemorrhagic bursa, what's the likely, is there a possibility of sepsis? Can that person become septic? Is it going to cause any other problems? So actually, intervening quickly is quite important. Question for you though. So in terms of palpating that area, obviously it's quite a sensitive area.
Yeah.
Do you look to have a chaperone, or obviously you get consent on an ongoing basis, but would you look to have a chaperone? Or
I think it depends what's on your index of suspicion, isn't it? Because there are certain things that you might have a suspicion for that you're not going to be able to accurately palpate, and therefore would you have a chaperone for palpation of a hamstring tendon? Do you know?
Yeah.
There are some other things around the area that you might want to palpate for, which are kind of probably beyond our chat today, which I know we've spoken about before, but those sorts of things, yeah, absolutely, you would need a chaperone because but you'd have to know what you were looking for with that and know where to palpate, because otherwise there's some things that masquerade for sure around that, and you only really get them in cyclists. You don't really tend to get them in, I mean, you probably get them in rowers as well, but they're not well reported on. So yeah, I think it's just use your judgment, isn't it? And it depends on what you're looking at.
And I suppose it depends on the patient as well, doesn't it?
Yeah, they might tell you though. They might say, "Well, I've had a good look in the mirror and I found this lump X, Y, Z." And to be honest, are you going to palpate it, or is that going to raise your suspicion enough to say off you go for imaging anyway? So
there's something to consider, isn't it?
Yeah.
What? Go on, you go first.
I was going to say, because I guess I'd say like the kind of ischial tuberosity is like a really common site, as we were talking about, in terms of kind of perhaps misdiagnosis, or not misdiagnosis, but another reason for some structural problems. But I don't know how many times you obviously get the cyclists with anterior knee pain, but what about the cyclists with medial knee pain? Do you see many of them?
Do you know, at the moment, I haven't seen anybody with medial knee pain. Any cyclist with medial knee pain.
Yeah.
Quite a while. I don't know if it's the standard of bike fitting in London in the shops has improved, or people have cleaned themselves off a bit more. I'm not sure, but I haven't seen anything for a while. The last case of medial knee pain, which we did chat about, that I saw, which I thought was really interesting, something that we probably don't think about enough, and maybe, I don't know, you can tell me if it comes up in cyclists, is a Safinous nerve irritation.
Yeah.
Is that something you see in cyclists?
Well, I think if you think about, knee pain in cyclists, generally it's going to be anterior or posterior, because you've got a sagittal plane motion, and the patellar sort of fulcrum is going to take most of the load, really, and it'll project that stress either into the PFJ or the soft tissues around. But when you start to get, it's not to say you can't get pain in other sites, but it's less likely. So yeah, how often do you come across a Safinous nerve, and actually is it more likely to be something else? Well, potentially, if you think about the mechanism.
The ones I've seen generally have been involving, there's been a contact involved of some sort, but I'm just wondering, because it sometimes tracks through the MCL, whether or not, if there's a medial stress going on, if that can become irritated, because obviously it can track around to just below the fat pad.
Well, it can, yeah, absolutely. So, sometimes, you do get cyclists with medial knee pain, and a lot of the time people come to me with a bike fit and they go, "Oh yeah, I've been diagnosed with a meniscal problem." But actually, what's the likelihood of having a meniscal problem on the bike?
Yeah,
it can happen. Absolutely can. The meniscocapsular kind of structures really can become irritated, especially if you change the stance width and things. But actually, what happens if someone's come off the bike, they bang the knee on the frame, and they've injured that Safinous nerve? Absolutely, you've got to consider that as a source of problem for that individual. Yeah,
because that's where the history becomes very important, doesn't it? Like, have I asked them? I must say, I'm sure you find it too, as I go on in my career, the big thing really is the subjective interview more than anything else. I mean, we were always told it at uni, and we've done it, but it definitely is a big thing, isn't it? It's interesting. I've spent some time with some sports medicine docs recently, and they like a lot of docs tend to have 4 or 5 key questions, which do tell you most of what you need to know. But we have that luxury of a little bit of extra time typically, where we can just get that little bit more out, which can make a difference as well. Just to be a bit
Well, I
more
tell you,
certain.
there's another extra articular structure in the medial knee that is often a source of medial knee pain.
Yes,
Any go on.
Pezanserine.
Yeah. Commonly, how many times does someone say, "Oh, the inside of my knee hurts"? And again, just like with the kind of ischial tuberosity pain being often a bursa, pezanserine, because you've got that kind of stress through a big range of motion on the knee, and you're right, if you've got a little bit of a kind of medial to lateral stress or a kind of dynamic valve, absolutely.
Yeah, and again, I think it's, I think we come across all of these in our career at some stage. And I think sometimes we forget what we do know and what we've come across, and we exclude it for a little while, and then something brings it to the forefront of our mind again. So again, I think it comes back to when you're seeing someone, having a good think about what else could be in the area, and what else have I seen there before, and what other diagnoses could there be, and then trying to be and then being a bit more thorough in terms of thought. I think that's what makes the difference, isn't it? Especially for me, anyway, in clinic. And again, with cyclists, you've got to think about, as you say, have they had a fall? Have they changed anything on their bike? Have they changed their stance width? Maybe saddle height? All of those things. Or have they upped their mileage massively? What else? Do they ride a different bike when they commute, or when they actually race? Just asking all those questions again, isn't it? And just trying to figure out the mechanism.
It is. And if you think about the kind of pezanserine clientele, there might be a little bit more elderly, so you start to think, okay, well, maybe what's going on in their medial joint. But then you think, well, it doesn't make sense because the load is very small and that just doesn't fit with the pattern. But actually, quite a lot of recreational cyclists will have their saddle set quite low because of getting onto the bike. So they'll often sit on the saddle and just have their feet, so they're kind of flat on the floor. And that for them becomes an accessibility issue, because obviously they have to do that to get on the bike, because a balance impairment, etc., might mean that they can't safely do it otherwise. But then all it means is they're just stressing through that area. And I've had some success actually with these guys who really struggle. Same for anterior knee pain. It's actually to just put a dropper seat post on them, because if you put a dropper seat post on, they can have the saddle at the low height then for their push off, and then they can just press a button, the saddle height goes up, and then it problem solved. Job done.
And as you say, that accessibility is incredible, isn't it? So if you can change that, not only do you help with their knee pain, but then it means that they're, well, perhaps something that's very important to them is something they can still continue to do. And obviously the health benefits, the cardiovascular benefits, the social benefits are all there, So not only have you impacted their their knee pain, but you've changed, well, it sounds massive, changed their lives, but made their lives more comfortable at least. Yeah, it's interesting, isn't it?
Definitely. Yeah. I think another one that we were chatting about was kind of leg pain, generalized leg pain, posterior leg pain, all sorts of kind of vague, weird-esque symptoms that can be tricky to get to the bottom of just in the someone who doesn't cycle, let alone when you add the biomechanics of cycling in.
Yeah, I mean, I don't know about you, but when I see someone with posterior leg pain, obviously you start with your basis, don't you? Sciatica, it's obviously a catch-all term, but is there any disc involvement? Then is it neural? Is it muscular? And then the one for me, which I think people forget sometimes, which we all do, of course, we're all human, is a vascular cause. And I think that's something we need to think about in quite a bit, don't we? Because those compressive forces. I mean, what are the I mean, there's some obviously that I'm aware of, more lower limb vascular wise anyway, things like popliteal artery entrapment. Is that something you've seen in many cyclists? I've
I would
seen.
say no, I haven't. But that obviously doesn't mean it exists. It just means that they might not have come to you. And also, if you think about who it affects and how it gets diagnosed, well, sometimes it might not be easy to pick up on like the first instance, because people don't always consider them problems. They just say, oh, I thought it was like a normal part of, cycling, or oh, my leg, I get cramp because I haven't taken on enough salts, or I'm dehydrated. But the reality is actually cramping as a vascular cause could potentially be more likely. So it's really important to try and screen. And I, historically, I don't know about you, but you ask people things 3 times and you can get 3 different answers to those questions in the same person, and perception's kind of key.
Yeah, I think also, again, I think you're right. You can ask the question, and that's where I suppose if your reasoning is good and you've ruled out all the other causes, and you're only left with one, and you're considering vascular, how do you go about proving it? That's the challenge, isn't it? I mean, you're right, and I think that I think you're right about people dismissing it. So I did some work with a rugby player many years ago now who had been seen before, and it's interesting. He'd come into our treatment room about halfway through training session and said, "Oh, I keep getting these cramps when we do really high intensity sessions. Not sure what to do." And myself and the lead physio I was working with, a really great woman called Michelle Cuthbert, looked at each other and was like, both kind of smiled, because we, for whatever reason, we're both thinking along the same lines at exactly the same time. I said, "Oh, have you treatment before?" And he goes, "Yeah, I was told my calves are tight, stretch my calves, but it doesn't work." Just because of the nature of what he reported, we both thought something vascular, and said, and he had a bilateral popliteal artery entrapment, and with high intensity exercise, obviously the muscles would fill with blood, tighten up, put pressure across the popliteal artery, and then he'd get cramp. Stretch and it would go away, of course. So it's interesting. I think if they've seen someone before, or if you've ruled out all the causes, then you have to think again a bit laterally, don't you, about what other structures are in the area, what else could be causing that, and why.
You've also got to think about the demands, like when you cycle, it's a heavy cardiovascular exercise, and you've got to ask about the intensity and the position, because there's something else. I think you're aware of this, aren't you? External iliac artery can become symptomatic as well, and you can get compression around the groin, basically. And there are lots of reasons why that can happen. You can get hyperflexion, generally might cause kind of kinking of the artery, but also you might be that you get compression from the anatomical structures around it, like your psoas, etc. I mean, and that's going to lead to really vague symptoms. The leg feeling dead. Often these guys say, "I just feel like I can't get the power out at high intensity. I'm fine if I'm upright," but especially, more so in a time trial position. And that's really hard to diagnose. I mean, there's a really good paper by Lim, I think it's 2019, and he along with some others go through some of the kind of main types that you can get, but also like mean average diagnosis time. It's crazy. Some of these people can be going around for 5-10 years, just like other vascular problems, and it hasn't been thought of. And how easy would it be to attribute that to, oh, well, your muscles just don't function in a lengthened position, or actually your intensity, and that you have to really kind of look at someone in that position in order to identify through blood pressure testing if there's a potential reason for that. There's actually a specialist centre over in Europe that diagnoses this, because I think they just realise there are a lot of people struggling and not getting picked up through local services.
I know there's especially for popliteal artery entrapment, but there is a good vascular centre here in London. I think as a Guy's hospital. I need to check, but there's a professor called Professor Loftus who does a lot with popliteal artery entrapment. Lower limb vascular stuff is his specialist area. I'm not sure about the external iliac artery, but he definitely with popliteal arteries got a special interest. But again, I think it comes back to, as you said, the time to diagnosis, like lots of problems. I think, again, as physios sometimes, and I've been guilty of it in the past, I'm sure we all have, we tend not to listen to our patients well enough sometimes. I think our patients will generally tell us what's happening and what's wrong. I think the issue is we tend to poo-poo it and dismiss it because we think, oh, it'll be fine, or we just don't think of vascular as a cause. But I think if we try treatment and the patient still isn't getting better, or it's vague, then the onus is on us to figure out what's happening, not on the patient. And we need to question, what are we missing? It's not so much, oh, the patient is fine, they need to crack on with it. It's, okay, what have I missed, or what have I potentially missed in this case? I think it's that reflection, I suppose, in action and on action, which, when you're doing physio school is not a really sexy topic, but actually in the real world makes a huge difference to what we do. Are we getting it right? I think we can get a bit lazy. I have been in the past, I'm sure we all have again, but it's really important to just think, what am I missing? What have I not thought about? And it's hard work, isn't it? But it's what makes the job interesting.
I'd be interested actually to see, for those of you that kind of watch this or listen to this, and hopefully people have found it kind of useful, but it'd be really interesting to see what other people bring to the table, because obviously, you learn from things, don't you? And you go, yeah, this, as you say, this isn't right. You might send someone off for a second opinion or something, and then what have you had any instances where that diagnosis that you thought were correct have come back and been something else in the cyclists? Well, I suppose in general, but in cyclists, because how much are we taught that the bursa is not really likely to be an issue, but actually in cyclists it is.
Yeah, exactly. Again, I think it comes back to, I haven't had so much an example with cyclists, but definitely with popliteal artery entrapment. I saw one as a student, which stuck with me, which was great. But also, I had one a number of years ago in a fit and healthy 20-odd-year-old, didn't smoke, didn't drink, no risk factors for any vascular issues at all. And a vague complaint of calf and foot pain occasion would come and go. Initially diagnosed as plantar fasciitis. Was given insoles, that wasn't changing it. I should say not diagnosed by me. In fact, and it was by one of my colleagues who literally just seen him in a drop-in clinic. So, it wasn't, and my colleague's absolutely superb, and given more time, would have definitely got to it as well. But I remember seeing this guy and thinking, okay, this doesn't fit any pattern that I've seen before. Therefore, what else is left to look at? And it was just, again, as you say, so vague. And I think he'd been grumbling about it for about 6 months. So actually, in terms of vascular issues, quite a short period of time. But we were lucky enough to have access to Professor Loftus and got him scanned, and he had, again, bilateral issues. Eventually needed surgery because conservative management wasn't working. But again, it's that, as you say, we're sometimes poo-pooed. How many times would that guy have got dismissed as, oh, it's just foot pain, or, maybe it's your footwear, change that, it's your fault, or you should try and rest more or stretch more, rather than saying, okay, well, the patient maybe is right, so what do we need to figure out, So that's kind of gone off tangent really from your question there, but I think, again, it comes back to, it's really important to just think a bit differently, and as you say, we get told that, oh, it's not the bursa, it's not this, but actually think for ourselves, I suppose, as physios. I think that's the important thing, and don't be afraid to ask. I mean, I often drop you a line and say, well, what do you think, B? Or, don't be afraid to ask other people what their opinions are. Mightn't be something we agree with, but you know what, it could be right, and it's always worth a check. I think we've got to be careful when we. I think you've heard me say this before, it's important to have an ego and a sense of self-worth, and that's not an issue at all. But egotism, where you suddenly think you're better than everybody else, is a real issue. So if you can get if you can share and talk about stuff clinically and pick somebody else's brains, I think it's hugely important. And that means then that we don't miss things, or of course we will, but we miss less, hopefully. And at the end of the day, that's what sparked this session, isn't it? That, I was thinking, well, what else do you think about when you see somebody come in with what's supposed to be hamstring tendinopathy? What else are you thinking about? And why, as a cyclist, what else would you be thinking about? What else would you change? As you say, we've got enough for another session out of it, but
exactly, yeah. Speaking of another session, yeah, we had a lot of questions from you, didn't we, to chat about? So I think that's probably a good half an hour's worth of chat today, which is probably I think all of our limits for podcasts and things, isn't it? But we've got some stuff planned. Well, actually, we need to plan a date, don't we? But if anyone's kind of got questions, if you're a physio and you're thinking, right, well, yeah, I've seen this diagnosis in a cyclist, but I'm not sure how to manage it, or what can I do about improving my knowledge on cycling injuries, drop Moss a line, because we're going to have a chat about some other things and try and bridge that gap a little bit between bike fit and physio, really.
Yeah, bike fit.
Moss, we should have said, if anyone wants to get in touch with you, what's the best way to reach you?
That's a good question. I suppose Twitter
is an Italian-themed Instagram handle.
Yeah, so and you can pop it up on the webinar notes if you want. But so my themed Instagram handle, as you said, I'm trying to remember, is Barba. So BARBA _Rossa. So ROSSAFISIO. So Barbara Rossa Physio on Instagram or on Twitter. Again, X as it now is called, at Barbara Physio, so at Barbara Rossa Physio. But as if they drop a line on the after show notes, we can probably pick it up from there.
Yeah. Awesome. Right. I hope everyone's learned some stuff, and I guess we'll be back at some point soon. So I hope you enjoy.
Fab. Thanks, Erica. Thanks for your time. Always a pleasure.